Hi, my name is Morgan Coulter. The date is August 3rd of 2020. Whoops, sorry. Um, and this is my video for the Unit 2 case connections with the two different case studies. The first case study I did was case number 3. And in this case study, a 5-year-old boy is brought to a pediatrician's office where his mother reports symptoms of drowsiness, persistent thirst, and frequent urination. The child has his blood drawn to measure the insulin at the time 0 and then again 1 hour after a glucose loading test. The serum insulin test is usually used to measure abnormal insulin levels in the blood. The first question of the case study asks asks what the information suggests is the underlying biochemical basis for the patient's symptoms. My first thought when reading the case study was that the child has a type of diabetes, since persistent thirst and frequent urination are common symptoms of diabetes. And I just know that from working at my job in the doctor's office that I work at. So when I read that, the first thing that came to mind was diabetes. After reviewing the child's serum insulin levels, it is likely that the child has type 1 diabetes. Type 1 diabetes is also more common with children and is the type of diabetes that arises when you're a child. So compared to type 2 diabetes, he most likely has type 1. Insulin is a hormone that allows cells to take in glucose. Glucose is the body's primary source of energy, and it usually rises following meals, leading to the pancreas to produce insulin and release it into the blood. Diabetes is also the most common cause of blood sugar fluctuations. Insulin levels are often very low in individuals with type 1 diabetes. The 5-year-old's serum insulin levels at the baseline blood sample were low compared to normal blood levels, or insulin levels, sorry. And this insinuated the possibility of type 1 diabetes in the child. The second question in the case study asks what the predicted fasting blood glucose levels are for the patient, given his current condition. This question is asking if the blood glucose levels are above normal range, within the normal range, or below the normal range. Using the information provided, it can be predicted that the patient's fasting blood glucose levels will be above normal range. When insulin levels are low, less glucose is used and more is left in the bloodstream, causing blood glucose levels to be high in patients with diabetes. The patient's insulin levels were lower than they should have been, which there was less glucose used and more that was in the blood. This would cause the patient's fasting blood glucose level to be high. The third question in the case study asks which two regulatory enzymes are likely to be active in the patient's current condition. AMP activated protein kinase is an enzyme known to regulate metabolism. The enzyme is activated when energy levels are low in the cell, and AMP activated protein kinase signals through substrates to restore normal energy levels. This is done by stimulating processes that produce ATP and preventing processes that use ATP. AMP-activated protein kinase improves insulin sensitivity and glucose homeostasis. Glucose 6-phosphatase also reflects similar changes in insulin and glucagon levels, accompanying diabetes. When glucose 6-phosphatase expression is elevated, it indicates that it's important for glucose homeostasis in both normal and abnormal states. And that was all I had for case study 3. The next case study I did was case study 4. Case study 4 describes a 2-month-old female that has jittery spells after breastfeeding, difficulty sleeping, an enlarged liver, low blood sugar, and abnormal fasting blood glucose levels. The question attached to the case study gave several answer choices and asks which diagnosis the 2-month-old female most likely has in this case. And it asks to pick which diagnosis you thought was correct and then explain why it was correct and why the other ones were incorrect. In my research, I found that the patient most likely has glycogen storage disease. The symptoms of this disease are very similar to the symptoms the baby is presenting, such as low blood sugar, high level of lactate, and an enlarged liver. A biopsy of the child's liver could be completed to confirm the diagnosis and to be more accurate. The child most likely does not have hereditary fructose intolerance because the symptoms of hereditary fructose intolerance include vomiting and jaundice, which the child did not have vomiting and jaundice at that time, so it is most likely that they do not have hereditary fructose intolerance. The child does not seem to have galactosemia, since those symptoms often include convulsions, loss of appetite, and vomiting. And the baby did not have a loss of appetite since she was still breastfeeding, and she didn't have convulsions or vomiting again. So galactosemia is most likely not the diagnosis. Glucose 6-phosphate dehydrogenase deficiency is also not likely, since it most often affects males and has symptoms of fast heartbeat, an enlarged spleen, and paleness. The child was a female, so glucose 6-phosphate dehydrogenase deficiency is most likely in males and not females. So that's one factor contributing that it is probably not that. And the 2-month-old female did not have a fast heartbeat. She did not show having an enlarged spleen, and she did not show any paleness, which is an important symptom. So therefore, the child's symptoms mostly align with the symptoms of glycogen storage disease, and therefore we can estimate that the 2-month-old female has glycogen storage disease. I included my references in my Word document that I'm submitting, but I'll just go over them. So I used kidshealth.org, ncbi.gov, pubmed.gov, and I used the hopkinsmedicine.org website, as well as the medlineplus.gov, and I use kidshealth.org again. I use that for a couple different topics in these case studies. So again, my name is Morgan Coulter. It's August 3rd of 2020, and thank you for watching. Bye.